Yes, yes, yes.
Yeah, let's start our session today. It is a miscellaneous cases. Let's start with
Yes,
our first colleague.
yes, she's ready. She's ready. Okay.
Assalamu
Okay,
alaikum, sir.
welcome. Alaikum salam. What happened? Sorry. Can you see my screen well?
Yes, sir. The frontal projection of the knees.
Yes, okay. Great. Take care, my colleagues, of cases of today's. Almost it is resembling actual exam. 6 case. 4 of them are usual exam cases, regular, and 1 or 2 of them are difficult cases, and this is the normal scenario. My colleague, this is a 70-year-old female patient complaining of left knee pain after falling. She has a history of right hip replacement. You can go on.
Okay, sir. So these are the X-ray frontal projection of the knees in the standing position. I can see that there is diffuse generalized osteopenia in keeping with patient's age. However, there is bilateral symmetrical periosteal reaction in the long bones, predominantly involving the fibula, the
Excellent.
proximal tibia, and the distal femora. No soft tissue component is seen. Mild degenerative changes are noted. There is no acute traumatic injury. And I would like to see lateral views as well to see any joint diffusion, etc. My first differential in an elderly patient with bilateral symmetrical periosteal reaction would be hypertrophic osteoarthropathy, in which case I would request a chest X-ray or a CT scan of the chest. The second differential would be thyroid acropathy. So I would like to see an ultrasound of the thyroid or an orbital CT to exclude my findings. I do not see any vascular calcification, so vascular insufficiency is less likely in this case.
What is your first possibility here? Thyroid
So
octopathy,
hypertrophic.
acropathy, or something else?
Sir, because it's a female patient, so I think we can first go for thyroid acropathy rather than
Are you sure?
some lung.
Are you sure? Thyroid acrobacy? What the
I
meaning
think
of
thyroid acropathy mostly involves hands, so I think
Yes.
yes. So this is hypertrophic osteoarthropathy, secondary
So
type.
what is your next step?
So as a chest X-ray or a CT scan of the chest.
Chest X-ray. What happened?
Okay, so I can see that there is an inhomogeneous opacity in the left upper zone with overlying destruction of the ribs and bilateral hilar lymphadenopathy, volume loss in the left lung and mediastinal shift. This is all in keeping with a malignant looking lesion, especially the rib destruction. So I would
Where is the
recommend a
destruction?
contrast.
1 second. Doctor, where is the rib destruction?
Okay, so
Which rib
first,
and which
second, third.
segment?
Okay, so second rib anteriorly, the part of
Okay,
third
maybe.
rib,
Okay,
part
so
of third rib.
what? Continue,
So,
continue.
so these findings of inhomogeneous opacity in the left upper zone with rib destruction, I'm thinking of an aggressive lesion in the left lung, and I would recommend contrast enhanced CT scan of the chest in this patient for further assessment of my findings.
Excellent.
Okay, so I can see that there's a high density opacity, high density attenuation area, which has spiculated margins, and it is abutting the mediastinal mediastinum, and it is also reaching up to the pleura. I would like to see it on a soft tissue window to see any calcifications. This is also yes, surrounding area also shows ground glass pacification. I would like to see mediastinal window for lymph nodal involvement. and the bone window for bony involvement, and also for any. Okay, so I can see that there is adjacent pleural thickening. There is redemonstration of the same speculated mass. And I would like to see the lymph nodes. Can you, sir, go to the hilum? Yes, so yes, yes, lymph nodes are also enlarged on the left side. So this is in keeping with a malignant-looking lesion. If there are any contrast-enhanced scans available, I will also rule out any
In contrast,
pulmonary embolism.
what is your final diagnosis?
So my principal diagnosis is a lung cancer in this case, and this patient will require, because this lesion is closely related to the bronchus, so this can be EBUS endobronchial ultrasound biopsy can be performed, and the next patient will require a staging CT, which will include abdomen in the contrast-enhanced portal venous phase, and next PET imaging for distant mets, and referral to the pulmonary MDT for
Excellent.
the
But if
management
if I ask you which of the three procedures should be done first,
which three procedures?
you talk about biopsy, CT staging, and PET CT. Which one of them do you prefer to start with, and why?
If the patient is already in the department, CT abdomen portal venous phase for the mets in the abdomen can be done right away. And endobronchial ultrasound biopsy is also a day care procedure, so that can also be done second, and third will be PET, lastly MDT referral.
Okay, doctor. Doctor, if I ask you, by the way, there are something need recorrection. I will recorrect during my comment. But if I ask you, how could you do a biopsy from this patient? I will give you, this is the lung window. How could you? The word how means the procedure, the direction, everything. The proper selection of slice, and either it is pro, anterior, posterior, lateral. This is what meant by how.
Okay. So
By
can
the way,
you
by the way, this is very difficult question, but as I promised all of you before, I'm trying to prepare all of you to the most unexpected question.
So initially, I said that EBUS can be done. I would like to review again if this is closely related to the left main bronchus or segmental bronchus. Okay, so no, the lesion is away from the bronchus. I think CT-guided biopsy percutaneous can be done.
Okay.
Posterior approach will be appropriate. Initially, I will check all the contraindications to see the patient has any bleeding diathesis. If the INR is above 1.5 or a platelet count is less than 50,000, this will be a contraindication. Or if the patient is unwilling, or if the patient is unable to hold breath, I do not see any emphysematous changes which would make contraindication for biopsy. And lastly, if all these contraindications have been included, then I think a lateral approach or a posterior approach seems
Thank you, doctor, so much.
appropriate in this case.
You did very well. If I am examiner, I will pass you. You are confident, clear, and concise. Let's start from the first image. This is a case of trauma, but there are incidental finding. Hypertrophic pulmonary osteoarthropathy. Don't talk about thyroid or acropathy at all, especially the patient is 70. Okay? 70. This is number one. Number two, thyroid acropathy means hand with soft tissue and periosteal, fluffy periosteal action. It is another scenario. This is the first very important point here. But you did well, really, here. Number two here, very nice pickup, but it is better to tell doctor the opacity, because really we can't judge 100% either this mass or pneumonia. So better to tell opacity, left upper zone opacity. Doctor, the first three segment of left three reps are obscured. Could you change the window? Because if we have windowing here, you will see the reps clearly. But at least you can use the term obscure the anterior segment of upper left reps. Second, you forget to talk about the volume loss here. Shifting mediastinum, elevating the diaphragm. Okay, doctor, you are with me?
Yes, yes, sir.
Okay. This is important to be mentioned because this very easy. يعني this very easy comments, but the examiner may demarcate you because all of these are one process. We should why? Because if this pneumonia, it will not cause volume loss. So, doctor, it is an opacity obscuring anterior ribs and causing volume loss at the left side in the form of shifting of mediastinal and elevating left hemidiaphragm. So, doctor, most probably this is a mass. Okay. Okay, because if you look very carefully, it is a little bit ill-defined, a little bit. So it may be confusing. If I didn't show you this one, and I told you patient have chest pain, really you will not be sure, and you will talk generally about this. Okay. Second, third, here you did very well, but take care. Nowadays, most recently, after diagnosis of, you forget to talk about the bilateral apical centrilobular emphysematous changes. So this patient is a smoker, and this is very important predisposing factor for cancer lung. Okay, doctor? You forget to see, doctor. Nowadays, PET CT is the second issue we should do after or before biopsy. Okay, why? Because we don't know the viable tissue here. When we did PET CT, I think this is PET CT, look, the PET CT demarcate which part is viable, so it will guide the proper site of biopsy. This is very important sign. Why? Suppose all of this is necrosis, and you go here, you will give a necrotic tissue. Okay, doctor. So the second step, better to do PET CT. Why? Not for metastatic workup. No. Why? Because of viability of tissue and the excluded and directed the proper biopsy location. It's very important now. Okay. Besides that, CT staging. Okay. And if I'm asking about some intervention, why? This lesion is almost peripheral and set here touching the chest wall. Okay. I think it is very near, very far from being biopsied through endoscopy. So it will be CT guided. Which part we choose? We choose the viable part, the most near part from the surface. And it is better to this part to be touching the pleura. Why? Why?
In
Because
order to
we
reduce the
want to
chances of
Mm.
pneumothorax.
What? Reduce what?
Chances of pneumothorax.
Excellent.
To re-
See, my colleagues, if you go from here, almost you will complication in the form of pneumothorax, and also from here. Suppose all of this lesion is viable, okay, like we saw in the PET CT, it is better to go from here. Why? Look here, this is the pleura. Here the lesion completely inseparable from the pleura. This location lateral. I didn't mean to go through the scapula or the muscle, but from here, okay, we can go up, and we can go from lateral. But here, too little bit lateral is difficult because of the scapula. Anyway, we choose in the lung the part which abutting or infiltrates the pleura. Why? When you are taking a biopsy from the lung, you're choosing for unhealthy pleura. This is the golden rule. Unhealthy pleura or infiltrated. This is means hopefully no pneumothorax. Okay, you are trying to choose the best plan for sure. Yani you don't choose a plan you will go through axillary vessel or bone or like this. But I'm talking generally. At least you will tell the examiner, doctor, I will choose the nearest part from the pleura, and it is better to be infiltrated the pleura to get unhealthy pleura. Okay, my colleagues. This is lung cancer is very important, either in long reporting, in short reporting, and in oral. Sure. Thank you, doctor, so much. Next candidate.
Yes, I'm here. Good evening.
Welcome. Good evening. 1 second. We finish this one. This is 30-year-old female patient presented with abdominal pain and heavy menstrual bleeding. You can go on.
So I have presented with female patient 30 years old with menstrual bleeding, heavy menstrual bleeding and pain. You can see in the ultrasound a few images that showing that the uterus has a heterogeneous appearance and with normal endometrial thickness. This is heterogeneity. Accompanied by a little hyperemia. Can we scroll again within the image? Okay. Okay, next. Can see. Okay, next. So most probably this is a posterior mass lesion seen in the posterior myometrium with stretching the myometrium over could represent focal adenomyomatosis. This is a primary diagnosis patient has pain and heavy menstrual cycle. I would like to ask the patient full history about the pain and if accompanied by the menstrual bleeding, and also I will shift the patient for MRI study to confirm my diagnosis and see if this is associated with endometriosis or other gynecological problems. So I have presented with MRI that is showing.
Doctor, if you wanted to take the control, request it, please.
Okay. So I have a
Leave the mouse. Leave, please. Leave. What happened? You close the case. I don't know what is the case. This is not the case. I think. Hmm.
No, we can see your WhatsApp screen.
This is mine because the case is lost. We has lost the case. A second. Okay, doctor, let me
I'm
scroll.
so yes, I'm sorry. I'm so sorry.
No problem.
So
اتفضل.
so I have presented with the sagittal MRI-T2 that showing heterogeneous mass lesions at posterior myometrium. These mass have a papillary, small papillary lesions inside and a heterogeneous appearance. It is filling most probably the maybe it is filling the endometrial cavity, or it is inside my inside endometrial cavity or at the posterior location. So I want to see if there is contrast enhancement or a dynamic study to see if this have the same myometrial enhancement or uh, it looks like it has a different differential enhancement between it and between myometrium. So most probably it is endometrial inside the endometrial cavity and causing posterior invasion to the myometrial wall. So if I can see the diffusion study, in the diffusion studies, there is no significant lymphadenopathy in the pelvis. It is also showing a little bit of diffusion restriction. So in the given clinical information, this is could represent endometrial lesion with a little diffusion restriction. So I'm thinking for either endometrial mass lesion or rare type of leiomyosarcoma or endometrial carcinoma. So I will refer it to sarcoma T, sarcoma.
Could you think endometrial
Sarcoma.
sarcoma? Could you think endometrial sarcoma is a reasonable differential in this age group?
No, it is to be rare and should be.
Okay, so we exclude endometrial sarcoma. Okay, second point. If I ask you to choose either a leiomyosarcoma or endometrial malignancy, which one will you choose and why? Look here and choose. Look here and choose.
It is low signal intensity.
What else? Is this endometrial malignancy or myometrial malignancy and why? Where is the main bulk of the lesion? Look here or here?
The endometrial cavity.
Yes, in the endometrial cavity. And where is the endometrial itself? Endometrium. Could you pick up it?
It was almost always invaded by the
It is
by the muscle.
replaced by
Only
this mass. See, it is replaced
yeah,
by this mass. And if you look here, there are some separation between the mass and the myometrium. And here
yeah,
also, correct? Look, it is
correct. Yes.
maybe cleft of fluid. So last answer for you, last choice, is it Is it endometrial or myometrial?
Endometrial.
Excellent. So, what's your differential diagnosis in this age group? Give me a suitable buzzword or a suitable differential. It is impossible to be
Maybe
endometrial carcinoma.
s- me- it could be endometrial carcinoma, endometrial polyp, or submucous fibroid.
No, it
These
looks
are the
like
differential.
malignant or benign.
Malignant.
Okay. You can tell the examiner, doctor, this is a malignancy of endometrium. Very easy. At least. Okay. Okay, doctor.
Uh,
Hello.
yes,
Hello. Okay.
yes, I'm here. Yes.
Okay. Thank you, doctor, so much. It is a confusing case, a typical. See, my colleagues, this is typical pathology, endometrial malignancy, but in a typical age. This is the FR2B exam. What happened here? If you look carefully, you will see that the uterus is totally distended by this heterogeneous, mainly hyper-echoic, hyper intense T2 lesion. Okay? And ask yourself, where is the endometrium? No endometrium. So it is originated from the endometrium. And what happened here? All of this soft tissue. Look here at the post contrast. What happened? What happened here? Here is hypo-enhancing, and this is very typical for endometrial malignancy. But here is soft tissue, solid component, and markedly heterogeneously enhanced. So we are dealing with a malignancy of the endometrium of atypical pathology. Okay? In this age group, we can tell the examiner, doctor, it looks like endometrial malignancy. If this patient over 50 or 60, I can put endometrial carcinoma, my first differential diagnosis. But this patient is 30. So I will put like sarcoma, endometrial sarcoma, or any other sarcomatous like number two. Okay, this is number two, leiomyosarcoma with endocavitary projection, like this. Okay, what is your next step? Gynecology MDT for biopsy, for further assessment, surgical treatment, chemo, whatever. Okay, okay, my colleagues. See the answers. It was endometrial stromal sarcoma, a typical endometrial malignancy. Some bits, some tips about the endometrial carcinoma. Number one, it is an old age tumor. Number two, it is a T2 tumor. You almost diagnose this in T2. Okay? Why? Because it is hypo-enhancing. Why it is hypo-enhancing? Because I'm talking about the typical endometrial carcinoma. Okay? The typical one. It is hypo-enhancing because it is adenocarcinoma. But in our case, it has a part which is hyper-enhancing. It is this part, as it is hyper-enhancing, this is sarcomatous. Okay, my colleague. Thank you so much, doctor. Next candidate.
Yes, sir.
Uh,
So can you hear me?
yes, doctor.
Okay,
One
sir.
second. Don't leave the mouse. Leave the mouse. One second.
Okay. So I have left.
I think this case. Okay. I finish this one. Doctor, this is 65-year-old male patient
Okay,
for
sir.
assessment of reaction to immunotherapy.
Okay, sir.
You can request control. Okay, go on.
Sir, just give me a second. Okay, I am provided with the CT abdomen and pelvis image of the patient who presented with for the to check the response of immunotherapy. So maybe patient is having some prior malignancy. I just want to scroll the entire stack first before commenting on anything. Okay, I am just going at the top ones. Okay, in my first quick scroll, the obvious abnormality I could appreciate was in the abdomen, and I think that there is mild pericardial effusion and pleural effusions as well, and pericardial thickening as well. But the most obvious abnormality was in the upper abdomen, where I could appreciate that there was a. Uh, just give me a second. It's jumping. Yeah, there was an aneurysmally dilated bowel loop with thickening. Likely, this is proximal jejunum that is involved with circumferential mass-like involvement and aneurysmal dilatation. I could not appreciate any upstream bowel dilatation. In addition to that, the liver and the spleen seem fine to me. I am looking for any retroperitoneal lymphadenopathy, though I could not appreciate any. So, based on these findings, I am thinking of lymphoma as my first differential, as there is aneurysmal dilatation of bowel loop without any obvious obstruction. I would
What
like to know
else?
if patient has, sorry.
What else other than lymphoma?
Other would be adenocarcinoma of the duodenum, but that mostly causes obstruction instead of this aneurysmal dilatation. There are few additional mesenteric lymph nodes as well. So these are my two top differentials. One is
Okay.
adenocarcinoma and other is lymphoma, and I would like to evaluate this patient further. I would like to first complete my staging by looking at the CT chest. In the lung window, I would also like to see the bones in the bone window. And for lymphoma, I would also like to go for a PET CT. As lymphomas are avid on PET scan, I would like to convey my findings to the primary and refer this patient to the oncology MDT.
Okay. Look here. Could you find anything in this slice?
So in this one,
This slice. Could
so
you find anything?
so just give me a second. I could appreciate. I'm looking at the trachea and the esophagus and the bowel loops. In
Don't
this
worry
given
about it.
slide,
Don't worry
okay.
about it. What else? Look at
I could
both
appreciate
axilla,
that.
please. Look at
Okay,
both
sir.
axilla.
Okay. So I could appreciate that there is stranding in the left axilla, and I could appreciate that there is a staple, likely representing a history of prior surgery in the patient. And uh, sir, can you show me the breast shadows? Is this a male or female patient?
You forget the history, and the examiner will never repeat the history.
Okay, sir. So I think that this is a male patient,
Okay? Okay, but
and there is
go
like, but
on.
there is,
What,
but
what
I think
happened
that
for the
there is.
skin here? 1 second. What happened for the skin here?
Sir, I could appreciate that there is mild. What should I use? The skin appears puckered and retracted.
Excellent.
I think,
So
sir,
what do you think of this lesion? What
sir,
what
I think
else other than lymphoma and adenocarcinoma in the bowel?
mets. This could be metastasis from the primary in the breast.
What primary, most common primary to
Sir,
metastasize
it
to
could be
the bowel.
some melanoma. It could be melanoma because there were some puckering in the skin and there were few surgical staples.
Excellent. Last point. Do you think there are something else here? What is this?
So there's a mesenteric bilobed mass and there is intussusception of the bowel loop likely due to the mass acting as a lead point.
Okay, so conclude and give me final diagnosis.
So, sir, this is a case of primary melanoma for which patient has been treated and is on immunotherapy with meds in the small bowel acting as a lead point and causing possible intussusception.
Okay. What is your next step?
So, I would like to see I would just want to complete the staging scan and then send the patient to the oncology MDT.
Okay, you
I
told
think
me there are
biopsy.
some
Uh,
intussusception. Is
yes,
there
sir.
are any urgency?
Yes, sir.
Yes
Yes,
or
sir.
no?
This interception. Yes, yes, sir. It's an emergency.
Emergency? Why?
Sir, because there is a lead point, so it will not reduce itself, and it will lead to the bowel ischemia eventually. So
Okay.
it needs to be conveyed because if it will be there, it will lead to some bowel ischemia.
Thank you, doctor, so much. Some learning point. Leave the mouse, please. Some very
Yes, sir.
important learning point for all of us. Please look at the exam from the first slice to the last one. By the way, I lost one Viva case because the answer was in the last cut, and I get one the opposite in from the last cut also. Okay, if we look here, we will find this duodenal mass lesion. Look here, very obvious. At least you focused here. This is very good. And you should tell me which loop. This is the colon. At least go up and down. Be sure this is not the colon, not the colon down, not the colon up. This is the colon. This one. Okay, this is not the colon. Okay, in the left upper region. So we are talking about duodenal loop. Okay, we look at all and see this is target sign. So we must tell there are circumferential long segmental mural thickening with intussusception and multiple mesenteric lymph nodes. Okay, like this, very enough for this region. And then you told me adenocarcinoma, lymphoma, and tell me about metastasis. This case educate us the importance of talking about all scenarios. If you told the examiner or doctor also metastasis, especially the patient is old, 65, is another or a third differential diagnosis, he will be happy and he will help you. Okay? And we should look to everything. Look here, if you look here, it is very subtle finding, and I know it is very difficult, but you can you must pick up this skin thickening due to this dentist's or surgical clips, whatever. What is this? When you look here, there are some surgery, and there are some thickening, and you missed very important lesion here. What is this, my doctor? What is this?
So these might be meds in the pericardium.
Pericardium. And what is this?
So this is lymph
What
node.
is this? Another one. This is a typical long reporting case. A typical. Okay, my colleagues, they adore to bring a case, like I told you in the all of you last session, the main pathology and the abdomen, but the key is a key in the upper cuts of the chest. Look here, my colleagues. Look, paramediastinal mass and pericardial mets. Okay, so it was a metastatic melanoma. Okay, metastatic melanoma. Whatever, if you didn't pick up all, يعني the final diagnosis, but at least you must tell the examiner at the major finding like intussusception, very important. Okay, and by the way, this is not an emergency. Why? because it causes incomplete obstruction. How could, doctor, we differentiate between complete obstruction and incomplete? Look after and before. Look here after or distal to the mass, there are normal passage of contrast. See? And air, there are air here. Okay? There are air. So it is an non-complete partial obstruction. So this is not emergency. This is very important question. Okay? Incomplete obstruction, you must find the transitional point. What is the transitional point? Look here. Look here. Incomplete. There are space here. Transitional point means, see the fluid and the gas, everything is very good. Transitional point means transforming or translation from complete blockage to collapse. So we should see here collapse if this complete obstruction. Thank you, doctor, so much. It was very fantastic case for reporting either for FRCR or our candidate from Arabic port. I forget to welcome all our candidates who attend from Arabic port. All of you are welcome. The study, all our sessions must be in English because it is an international overseas lecture. I tell all of you the radiology is the same in all postgraduate. Okay, the radiology is the same. So you can get many benefits from any lecture. Thank you, doctor, so much. It was a metastatic melanoma to the pericardium, paramediastinum, and the jejunum. Next candidate.
Assalamu alaikum, sir.
Assalam. Doctor, please, 1 second. 1 second. My colleague, I'd like to introduce to all of you my first consultant, my senior, Dr. Amal Sobhi, who teach me from the ABC of radiology. It is a great honor for me that she is now attending this very humble session for his discipline. Thank you, Dr. Amal, for your attendance. If you can hear me, please respond. Okay. Next candidate. Doctor, are you ready?
Yes, sir. Yes.
Okay, 1 second. This patient is 70-year-old male patient, have headache, have
These
left
are
arm
sections.
weakness. Oh, you can ask for control.
Yes.
1 second. Ask for control, please. Yeah, go on.
These are axial sections from CT brain.
Yes.
So I am
Yes.
unable to. Oh, yes.
The examiner will ask you many times to try. See, use the bar. Use the sidebar. No, leave. 1 second. 1 second. 1 second.
Yes.
Use the arrow. Is it scrollable? Okay, I will help you.
No, sir.
Go on. Go on.
And these are axial sections from contrast enhanced CT brain, in which I can appreciate that there is an area of edema not in left frontal lobe, multiple bilateral Ring enhancing lesions are noted in bilateral frontal lobes with marked peripheral brain parenchymal edema. The ring enhancement appears thin and smooth. However, significant brain parenchymal edema
Sure.
is noted,
One
no
second.
midline
One
shift seen.
second, doctor. Are you sure it is thin and smooth?
No, sir. Thick irregular. Yes,
Yeah.
sir.
So
Yes. Thick irregular enhancement is noted. I will scroll through all the images to look for other lesions.
what do you want? There are coronal.
Coronal and also sagittal images.
Enough. Coronal is more than enough.
Okay. Okay, so these are multiple ring enhancing lesions with thick irregular walls and surrounding significant brain parenchymal edema. No midline shift seen. I will rule out any basilar invagination, any herniation, tonsillar or uncal herniation to rule out its mass effect. On the basis of these images, my first differential would be metastatic deposits, as the patient is very old. So I will check the history of the patient and the previous record of the patient. If the patient is a known case of any malignancy, then these are most likely metastatic deposits. Other differential could be primary brain tumors or brain abscesses. However, I could not appreciate any significant meningeal thickening or enhancement in these images.
What is your
I
next
will
step?
also check.
What is your next step?
Next, yes, I will urgently refer the patient to a neurosurgical team for
Why
further
urgently,
assessment
doctor?
of.
No. 1 second. Why urgent? What is the
Um,
cause of urgency?
because of significant edema and okay, I will check the any herniation uh, or any hydrocephalus.
Did you find anything of
Okay,
them?
no. So I will refer the patient to neurosurgical team to rule out any primary malignancy if present. Otherwise, they will go for CT chest, abdomen, and pelvis for staging workup of this case.
What about this one, doctor? You didn't want to do this one? Am I right?
Yes.
Yeah. Why you
On
didn't ask?
MRI,
Why you
yes.
didn't ask? Are you finally diagnosed or diagnosed brain lesions like this without MRI? Too difficult.
No, sir.
Especially
I will also check.
you talk about abscess and the metastasis,
Yes.
and you didn't ask for me. Okay, let's talk about your differential abscess or metastasis. You compare between tumoral pathway and abscesses. Which sequence do you want?
DWI to check restriction.
What happened?
Uh, uh, no restriction is seen. It is
No,
post.
no, no. See,
It is
this
post
is
contrast.
sorry. This is postcon. This is
Yes.
DWR. What happened?
Yes. And the core is non-restricting. I will also check the ADC mapping
No, there
for
are
comparison.
peripheral restriction.
Yes,
Peripheral.
peripheral restriction. I will yes. So I
This
will
is the
correlate
ADC.
with the
This is ADC. So is this abscess or not?
no, this is not absent.
Okay. This is the post contrast. What's your differential diagnosis?
Most likely would be metastatic deposits.
Okay, what else?
And this can be toxoplasmosis.
Okay, but do you think toxoplasmosis has this extensive non-uniform mural enhancement? Do you think that?
No.
So,
So most likely these are metastatic deposits.
okay, if I show you this What is the name of this sequence?
T1.
Okay. If I show you this T1 and what is the name of this sequence?
This is DW, sorry, GRE?
What? Not GRE.
GRE.
No. GRE
Susceptibility
gradient.
weighting.
Okay,
Yes, yes,
gradient.
gradient or susceptibility.
Okay, what happened here?
Blooming artifacts. Hemorrhagic.
Okay,
I think these
what
are
does it mean?
hemorrhagic meds. Hemorrhagic meds.
Okay, hemorrhagic. Okay, or give me another differential. It may be yeah, not meds. Okay, most probably because it is multiple, it may be hemorrhagic meds. But what else?
So these can be melanoma meds as well.
Okay, what else? When the examiner are asking you what else, this means there are something in his mind you didn't reach.
Calcifications.
No, see, this is
Calcified.
tumor. Okay, containing SWI blooming artifact. Okay,
Yes.
you talk about hemorrhagic myths, and I didn't refuse. You talk about melanoma, I didn't refuse. What else? This is an old age, 60-year-old patient with lesion which has a central necrosis.
Multifocal glioblastoma.
Excellent. How could you differentiate between, for example, glioma, if we have suspicion, this is glioma or abscess? But for this
So,
case, it is very good abscess, by the way.
the glioma mostly cavitate, and the central wall is not restricting. However, abscess restrict.
Okay, what else? If I ask you about the MRCP, what is the differential point between glioma and abscess in MRCP?
So MRS.
MRS spectroscopy. Sorry, not MRCP. Sorry. I'm sorry.
Yes.
MR spectroscopy.
Sir,
Yes.
sir, on in glioblastoma, Na peak will be raised. However, in METs, and also in METs,
acetyl,
calling peak.
one second. In acetyl asparatate, where rest?
Yes, sir.
And what else?
Sir, choline is usually raised in METs.
Mm-hmm.
And sir, Na peak is decreased in multifocal glioma, and also choline peak is markedly raised in glioma.
Yes,
And
excellent. So
lipid
choline is
lactate,
raised. Choline is raised. NAA, in acetyl asparatate, is
uh,
decreased.
lipid
But
lactate.
yes,
So lipid lactate peak is also raised because of necrosis in glioma.
yeah, but no choline elevation in the abscess. Okay, thank you, doctor, so much.
Yes.
Look, my colleague, it was a multicentric glioblastoma. Doctor, I have a last question. Why glioblastoma is named glioblastoma multiforme? Why? Why
So
is
because
this
of
name different? What?
different entities like necrosis, as well as
Excellent.
different. Yes, sir.
Necrosis
And
and what
also
else?
different cells.
Yeah,
Sir,
yeah. You,
it
mm. Necrosis and what else?
necrosis, hemorrhage, and also variable morphology.
Excellent. So glioblastoma multiforme named after its pathological changes because it may contain cystic changes, hemorrhagic changes, okay, some growth. So the name given to it, it is mainly related to its pathological pattern. Thank you, doctor, so much. It was also
Thank
another atypical case, this is typical pathology, but we are not familiar to multiple lesions rounded, looks like really metastatic, very, very similar to be metastatic, and finally it was a pathological surprise. Okay, that it was a multicentric glioblastoma. Thank you, doctor, so much.
Thank you, sir. Thank you.
Next candidate.
Yes, Doc, I'm
Leave
here.
leave the mouse. Leave. Sorry, my colleague, in last case, we are doing MRS, not MRCV, sorry. MRS means MR spectroscopy. Choline is high because it is related to the high turnover of the cell. Okay? And N-acetyl aspartate, this is the normal neurotransmitter of the brain. So it is disturbed in glioblastoma multiforme. But like due to necrosis, we have lactate and maybe lipid also peak. Okay, my colleague. The abscess only have lactate and lipid peak. But the abscess is very clear from the imaging, especially DWI, peripheral smooth enhancement. And besides the clinical picture. Second, I forget, doctor, don't tell all of you, don't talk about anything urgent unless it is really urgent. Why? You can't imagine how busy the NHS hospitals. Really, you can't imagine. Okay? They are so busy. So if one clinician marked one case urgent, it must be an urgent, and he must rationalize that. Okay, my colleague. Thank you, doctor, so much. Next candidate.
Yes, Doc, I'm here.
Uh,